you've heard how complicated trying to do catheter-based repair is. So an alternative to that would be to do catheter-based mitral valve replacement. I'm going to just kind of give a brief overview of the challenges faced in this field. And then I'm going to talk about first-in-man experience with a device called Tendyne, and then Vinny will talk about first-in-man experience with the Edwards Fortis device. You've seen this slide. So what we're going to talk about in this talk is down here, the space of mitral valve replacement. And these are the various companies, or some of the companies, that are trying to develop catheter-based mitral valve replacement devices. There are billions of dollars being invested in this space. TAVI is here to stay, and we've now got over 100,000 implants. It's clearly an established technology. So why have we only got about 20 to 30 mitral valve implants? And the question is, it's very different. The aortic valve, I've always thought, but simplistically, is a valve in a tube. The pathology is all the same, pretty much. It's degenerative calcific aortic stenosis. Okay, the annulus is a bit elliptical. Not quite sure where it is, but it's a pretty straightforward environment to implant in. You know how complicated the mitral valve is. You have this very complex subvalvular apparatus which can interfere with both implantation and device function. You've got the complex structure of the annulus, which moves in 3 dimensions throughout the cardiac cycle. And this is looking at 3 different mitral annuluses: normal, ischemic, and myxomatous. And you see they move in different ways depending on what the pathology is. So it's a very complex pathophysiological environment. Even within degenerative disease, you've got a wide spectrum from sort of fibroelastic deficiency through to this sort of patient with very excess tissue, the Barlow or myxomatous valve. And something I think we're seeing a lot more in the UK now, these patients with Big Mac, mitral annular calcification, often elderly females, causing leaflet restriction and central mitral regurgitation. So a wide spectrum of degenerative disease. And here we have the sort of functional patient. Well, are they all the same? Well, of course they're not. There's symmetric and asymmetric tethering. So even within this functional or secondary space, there is a spectrum of disorders. We tend to forget about this disease. This is the most common problem worldwide, with an enormous burden of rheumatic mitral valve disease. Unfortunately, it may not be in countries that have large healthcare spending budgets at the moment. But if we're going to develop devices to treat mitral valve disease, we mustn't forget rheumatic disease. So what are the technical challenges for TMVI sizing? How do we fix it? Can you get sealing? And how do you get it there? These are big devices, and they often need big delivery systems. This is the attractive route for all the interventional cardiologists. This is going to be an extremely difficult challenge to get these devices across the septum and to orientate them in a way that you're going to be able to predictably place them in the mitral valve. Not impossible, but it's going to be a challenge. Most of the technology at the moment is being deployed transapically. Again, these sheaths are quite large. And I just wonder in the DCM patient with this kind of thinned out attenuated apex, whether the apical access site complications will be even more frequent than one sees with TAVI. Just to show, this is a concept of a transatrial approach through a right mini thoracotomy, and the one device that is being developed, which I think is close to clinical implantation with that, is the Medtronic device. So these are the kind of challenges, the diverse etiology, the complex anatomy and physiology. Particularly, I haven't mentioned the dynamic implant environment. You have to remember that the mitral valve closes at systolic pressure, whereas the aortic valve closes at diastolic pressure. So there's very different forces at play here. And then all these problems of problematic PVL, which is much more likely to give you hemolysis in the mitral space, left ventricular outflow tract obstruction, circumflex coronary arteries not far away at the back. So there's this is a much more complex space. So I think this is how I see it. This is like TAVI. I mean, pretty much all of us will be able to drive this car. Not many of us would be able to fly this aeroplane. I hope it's not an A320 cockpit, actually. Yeah. So transcatheter mitral valve implantation. There are 4 technologies that have been used. I've heard on the grapevine that a company called 12 may have done 1 or 2 implants, but I'm not certain. For the UK community, we're fortunate 2 of these 4 first-in-man implants have been done in the UK, and you hear about those today. First implant was Cardiac Q. This is a very tall device which sits up into the left atrium, so it doesn't give you LVOT problems, but there's a lot of potential stasis and problems with flow in the left atrium with this device. Neovasc Tiara, small number of implants mainly in Vancouver. A D-shaped valve. There's not been very many D-shaped valves implanted surgically, so I think some concerns there about durability. This is the Edwards Fortis device that Vinny will talk about next. And this is a highly specialized image of the Tendyne device, but I think it kind of shows you how it's supposed to work with this tether and an apical pad. So this is the Tendyne device. It's two nitinol frames, an inner circular and an outer shaped frame with a tether and this apical pad. And you can see here it's shaped anteriorly with this so-called proud cuff to sit on the anterior mitral annulus up towards the aortomitral continuity. We touched on this. CT planning is absolutely essential in planning these procedures. This is some of the sort of measurements that Nick Piazza generates from his software, which is called FluoroCT. Materialize is probably the daddy of all of these. This is software where you can also load 3D TOE and probably CMR images in, so that you may be able to develop a similar kind of imaging from other imaging modalities. And you can do virtual implants. You can implant whatever device you're going to go in and see how it might impact on the left ventricular outflow tract. So moving on to this is the 3rd patient we did with the Tendyne device, and these are the sort of measurements we're getting, measuring aortic annular mitral annular dimensions. Clearly, assessing the aortomitral angle is key in assessing the risk of left ventricular outflow tract obstruction. We then pseudo-implant the device to see what the outflow tract clearance would be after you have the device in place, and you're able to plan your chest wall access, the angulation of your instrumentation and your instruments. And this is the sort of summary of the measurements that we made with CT on each patient that we did. And the other thing that we did is make, through Mimics, a 3D print of the mitral valve of each of these patients and actually put the device that we were thinking of implanting into the 3D print. So a lot of effort in terms of sizing and planning. And then one of the things about Tendyne is they have multiple valve sizes. So here we have septolateral and commissure to commissure dimensions and perimeter of the mitral annulus. We have the various valve sizes, and you can choose a valve to give you a certain degree of oversizing. How much to oversize? I have to say I don't think we have a clue at the moment. So, but clearly some degree of oversizing. So just some images. As I said, this is the 3rd patient that we did. He was an 88-year-old gentleman, rather frail, clearly has degenerative disease, had near systemic pulmonary artery pressures, and about 2 weeks previously he'd had a hospital admission with severe congestive cardiac failure. So this is a Fogarty balloon going over a soft wire, just to make sure that we're not entrapped in the mitral annulus. Here is the insertion of the delivery system. The introducer is removed, and there's a continuous saline flush through the sheath to make sure that this is de-aired effectively. A lot of this procedure is done on 3D TOE. Whilst 3D TOE in some areas gives you pretty pictures, here it is really helpful and key. And so here is using 3D TOE to ensure that the sheath is centered in the appropriate position, going through the mitral valve into the atrium. And here's the device extruded from the sheath to about 75% of its implant. And that is done, as you can see, within the left atrium. So the device is partially deployed in the left atrium. And at that stage, you're able to use 3D theory, and you can rotate this so that you get this proud cuff angled up here towards the aorta. Going back to 2D, and this is pulling the device down into the annulus. So this is a partial deployment in the atrium, retraction into the annulus, and completion of the deployment intraannulally. This is some pictures during tensioning of the tether, and you can see here we've really got too much tethering on, having quite a bit of deformation of the left ventricular cavity. And here is the performance of the valve. This colour down here is the patient has mild AR, which the patient had before the procedure. There's no change in AR. For those of you who like fluoro, there's some fluoro pictures. This is the partially deployed device. And here is the fully deployed device. The tether runs from here to here. And this is a titanium spike that you puncture the tether with to hold it in place. These are the 3-month transthoracic echoes of this patient, showing a nicely seated device. Some AR, but maybe not the best picture, but very good valve function. So just to comment about Tendyne, we've done 3 implants in native valves and 1 valve in ring. These are done under the UK MHRA compassionate use protocol. Some features of Tendyne, which is unique, its ability to treat a relatively diverse range of pathologies, has multiple device sizes. I think for all of these technologies, patient selection is crucial, very detailed planning. Implantation actually is reasonably straightforward. It's a big sheath into the apex of the ventricle, but what we found is the apical pad actually makes a pretty effective apical closure device, so it's a byproduct of the pad. The outcomes we've had, I'm not at liberty to present, but you could always ask, are encouraging compared to the other days of TAVI. There's obviously a lot of technical issues, implant issues, sizing, tensioning needs to be resolved. And these are very, very early days. So I'll just leave you with going back to 3D, showing you pretty pictures. There's just a pretty picture of the valve working. Thank you very much.